Hello and welcome to FITsOnTheGo. My name is Dr. Saraschandra Vallabhajosyula and I'm a fellow in training at the Mayo Clinic in Rochester. With me is Dr. Manesh Patel, Professor of Medicine and Chief of Cardiology at the Duke University in Durham, North Carolina. Welcome, Dr. Patel.
Yeah, thanks for having me.
Thank you, Dr. Patel. So here, today we'll be discussing your DEFINE-FLAIR study, which is of great importance to general and interventional cardiologists worldwide. Can you tell us a few highlights from the study you just presented?
Yeah, so first it's important to recognize that DEFINE-FLAIR is a randomized trial evaluating two diagnostic strategies. And in over 2,000 patients, this was presented last ACC in 2017, led by Justin Davies and Javier Escanad. Patrick Soroyes and myself are some of the study co-chairs. These patients were randomized to one of two physiologic testing principles in the cath lab. The standard, as we know, is fractional flow reserve, or FFR. We recognize that actually fractional flow reserve measures pressures, not flow as much, right? So FFR with adenosine in half the patients and seeing what their clinical outcomes were, compared to iFR, a new technology looking in the diastolic wave-free period to see if there's an ischemic lesion. The findings of that trial were importantly similar. They showed that the clinical outcomes were similar between the two groups, and a Swedish group did a similar study, and so it made us feel comfortable that iFR could perform as FFR. Today, we presented results of the cost analysis. Now, it's important to remember it's a non-inferiority trial, so it's hard to always think about superiority or cost effectiveness when the two arms are similar. But what we found is that when we did a cost analysis using the actual costs from sites and then doing multiple sort of regression analysis for each cost input, we find that in overall the iFR arm is less costly, about $800 to $1,000, mainly driven by the fact that there's fewer unplanned revascularizations and there are fewer patients with myocardial infarctions, although small number, and then likely less cost through the procedure, time, adenosine, other things like that.
Wonderful. That is definitely will have a huge impact on our practice. What message do you have for clinicians and interventionalists who regularly use this, like in your lab and ours? How will this change our practice starting tomorrow?
Well, I guess the first thing I would say is that it's not used routinely, right? And one of the big messages for us, and one of the messages from the study is we don't really, and I don't personally care which of the physiologic measures you use. I just know that in the national use in the United States and around the world, it's less than 20%. So think about that. The number of patients you have in the cath lab where there is a equivocal lesion or a lesion where you want to be sure that you're stenting an ischemic causing lesion is less than 20%. So if we can remove barriers, whether it's cost, adenosine, ease of use, wire, any of those things, we'll continue to work towards that. Because I think strongly that if you can demonstrate that the lesion is ischemic causing, that's better than doing it without.
Wonderful. Oftentimes, with new studies coming out every year, fellows in training and interventional fellows in training are frequently inundated with the amount of literature to keep up. If you had a couple of important take-home messages for them, what would that be?
I guess I would say first for fellows in training, learning techniques. So myself and others, what you learn in fellowship is not what you do your whole life, right? So the idea to keep your mind open and the idea to say, I'm going to need to learn new techniques because they're going to be important. So when I trained, we used very little physiologic wires. Today, we do radial procedures with many more physiologic wires. These are all things I learned after my training. And so I guess the first message for fellows in training is keep a mind open, continual learning, part of what this is all about. The second is, in this study, the take-home points are, the outcomes are similar between the two arms. Cost was a little less with iFR. And in general, if you can use more physiologic guidance for your intervention, that'll be good.
Wonderful. Well, it was a pleasure to have you with us at ACC FITsOnTheGo. Thank you for your time, Dr. Patel.
Thanks for having me.
For more videos like this, please log on to youtube.com/FITsOnTheGo. Thank you.